Welcome to the Difference of 13 podcast, where we make a difference by doing it differently. Welcome back, everybody. It is a beautiful Friday afternoon, and Teri and I are excited to talk about our topics today. Heat and ice.
Fire and ice.
Fire and ice. Sorry, I'm still working on getting this stuff correct. That's the theme this week here at Par for Success. And if you guys do want to learn more about us and what we're doing here, we have lots of free resources on our website, parforsuccess.com. Should be up on the screen right now if you're watching this on YouTube. You can just click on the podcast little menu, and it'll take you. You can see all the other episodes that we've recorded, all three of them.
Yeah, number 4.
This is number 4. And I'd like to thank the person who gave us a thumbs down in the first 20 minutes that it was posted.
That was a little devastating.
We had to resuscitate Teri, whoever you are. We had to bring her back to life.
Caused much angst here.
Luckily, they took away your pistol permit, I think, right?
Yeah, it's probably good. Well, and that it's anonymous when you thumbs up or thumbs down.
Yes. So we've put in a request to YouTube to find that out so we could hopefully ease Teri's angst.
Yeah. Made me a little fiery.
It did, but we won't tell her I did it.
Yeah.
So this week we're going to talk about heat and ice, and particularly in the healthcare world. Everybody's been told your joint hurts or your back hurts, put ice on it. And that may not be the best advice from what a lot of the research has been saying.
Right. It surprised me because that's what I grew up on, is you're always supposed to ice everything. And when I've gone to other physical therapists, if I was sore or had an injury here, put a bag of ice on it. That was part of my hour of treatment, was spending a good 10, 15 minutes with a bag of ice, because I couldn't do that at home. I had to do it there.
Oops.
Yeah.
And then we're also going to talk about an exciting experience that left Teri quite fired up.
Yes.
Was that yesterday? Or
yeah, it was yesterday. It's still fresh.
Yeah, I actually asked her. She came in and started wanting to let off some heat, and I asked her to hold it in until today. So
I've been sitting on this for 24 hours.
Yeah, so we're going to get into all that today. So, and as always, guys, if you have questions, you have topics you'd like us to chat about, please send them in. If you'd like to see Teri continue to get irritated, please give us thumbs down. If you'd like to see Teri smile, thumbs up, work much better.
Right.
And we also have a couple exciting guests coming up in the next few weeks that we are lining up for interviews, and from a number of different industries. We actually have one guest coming on, I think, that has had quite the medical experience and still actually performed at a professional level athletic-wise.
It's truly amazing.
That's about all the
we'll just tease that out.
Teaser I'm going to give on that. So, but let's jump into ice and heat, and if I hurt my shoulder, do I ice it? What have you been told, Teri, as a patient, somebody who's experienced that?
It's always, put ice on it right away, because you don't want it to get inflamed, and it'll reduce swelling, and allegedly it's going to make it better.
And I think what it's called RICE, right? So,
right.
Rest, ice, compress, and elevate. And what was the name of the doctor that?
Gabe Merkin.
Dr. Gabe Merkin came up with that. I believe it was the 60s or 70s.
I think it was the 70s.
But yeah, and interestingly, he recanted that.
I know, that was pretty surprising.
A number of years ago, said that is not actually the way to go about taking care of injuries.
Yet a lot of people still insist on icing.
Yeah, how many PT students do we get to come in, and doctors that say ice, right?
Pretty much everyone. Yeah.
It blows my mind that the healthcare industry is still, and we're teaching new healthcare professionals to ice things, when the guy who came up with the idea of doing it says, no, don't do it. And there's a great guy. His nickname is the Anti-Ice Man. Was it Gary? I'm going to totally butcher his last name.
Reinl?
Gary Ryle, R-E-I-E-L. Is that right?
Yeah, I think so.
So apologize, Gary. We love what you're doing in your work. I'm sorry if we messed up your name. But yeah, I mean, the Anti-Ice Man says quite the opposite. He's actually spent, I think it's like 30 or 40 years researching, going through all the research on cryotherapy, which is the medical term, or the fancy term for ice, basically using ice for therapy. Mm-hmm. And he has a very different opinion.
What's his opinion?
I was waiting for that. Thank you. So basically, there are a number of research studies that have been done that actually show that when you ice, you actually increase scar tissue development or fibrotic tissue that actually leaves you in worse shape, 12, 16 weeks down the line, as opposed to if you did not ice. So I believe there was a study, I don't remember if it was total knees but basically there was a study where they had one group who iced and one group who did not. And instead of icing, they did active range of motion. They did more what we would consider the correct thing to do. Maybe some ice with some heat contrast to open up flow and get things really moving. But what they saw was in that first 72 hours, the people who iced did feel better. They actually reported better perceived pain. They actually felt like they felt better than the people who did not ice. But then you fast forward 12 weeks, and the people that iced were still having problems versus the people that did not and did therapy the other way actually were very good. And when they looked at the quality of the tissue in the people that did not ice was much more elastic, much healthier than the people who did. So when you're looking at long-term outcomes and, total knee replacement, and we slap the ice on there nonstop, that actually may not be the best way to take care of things.
So you're saying if you have an injury, should you ice it at all or no ice?
Well, I think that's the problem. Like in your mind, is inflammation good or bad? Like when you get swelling in an ankle, say you roll your ankle.
Yeah, everybody says it's bad.
Right. Well, that's actually the first stage of healing, is the inflammatory phase, which lasts 72 hours. So the analogy I like to use is if you think of on a highway, there's a big accident and it's in the middle of rush hour and none of the cars move. The ambulance can't get to the people who've been injured. That's essentially what ice does. Is it constricts the blood vessels so the white blood cells and the part coming through the blood that need to get there to clean up the injury can't get there. Now, it doesn't stop inflammation. If it did, we'd really be screwed.
Yeah.
But all it does is delay it. So when you ice, all you're doing is delaying that 72 hours from occurring. You're blocking the road so that the healthcare providers, quote unquote, can't get in to take care of who's been injured. And if you, let's say the swelling starts and then you ice it, you essentially box the ambulance and the first responders, you block them in, because then all the roads or the vein, basically the blood vessels are constricted and they can't get out. They can't get the junk out of there, the debris from the accident. So very similar when you have an accident and you have an injury in your ankle, you want to assist that inflammatory process. You want to clean everything out. And for some reason, that's totally lost.
Well, I think it's people don't want to be uncomfortable. I know when my boys were little and they ran a fever, all my friends were like, give them, Tylenol, give them Motrin, you want to bring the fever down. And their pediatrician actually said, if they're not uncomfortable, a fever's not the worst thing in the world. That's the body's natural defense to kill off the virus or bacteria that's in their body. Obviously, you don't want a little kid being super uncomfortable and you want to make sure it doesn't go too high. But, he's like, a fever's not a horrible thing, but it's our natural inclination to make it go away. They're still sick. You just artificially brought down the temperature, and that's their body's natural defense to getting better. So I was not always quick with the medications.
So ice and pills aren't always the answer?
No, shocking.
Whoa.
Yeah, which I was very happy to hear about this research because I hate ice. It's just too cold.
Well, so I think when you do look at how to handle an injury acutely, you wake up in the morning, your back is sore or your knee hurts after a long day at work, or maybe you were playing golf or tennis or some other activity. Ice is not always the way to go, and often, actually, I don't want to say never, but it's oftentimes not the right way to go. And honestly, any way that you can assist that inflammatory process in terms of making it more efficient, that's what we want to be doing. Our bodies have been around for a long, long, long time, the human race. They know what they're doing. What we want to do from a medical perspective is to assist the bodies in making them even more efficient. We really don't want to block them from healing that injury that's occurred there. So that's our myth buster, I guess, today.
Yeah, no, that's a good one, because everybody I know, as soon as they get injured, they grab that ice pack. So throw out the ice packs.
Yep.
You heard it here.
From Teri's mouth.
Yeah.
So speaking of from Teri's mouth, I want to hear the story from yesterday.
Okay.
I know you've been holding it in for a while, so I'm going to give you the floor here.
It was rough. I went to the doctor. As I said in a previous episode, I have Ehlers-Danlos, which causes a lot of joint pain. Ironically, people with Ehlers-Danlos don't do real well with taking narcotics, pain relievers. We metabolize them strangely, and they're not very effective. So finding something that reduces the joint pain is very challenging. I have tried so many different pills. It's unbelievable. And nothing has really worked. The one thing that kind of takes the edge off a little bit for me is a small dose of Valium. The last time I had a prescription for Valium filled was 2 years ago. So I was running out. It was a bottle of 30 pills. So I go to my primary care, and I was like, hey, joint pain's been really bad. I'm running out of Valium. Could you write me a new prescription? Nope, can't do it. Valium is a highly addictive medication, and I'm concerned about you getting addicted to it. And I was like, well, it's been 2 years since I had a prescription filled. That means over the course of 2 years, I've used less than 30 pills of Valium. I really don't think addiction's the problem. She insisted that we have to exhaust every other possibility first before we can try refilling Valium.
12 surgeries wasn't enough options exhausted.
No, and the myriad of other pain meds that I have tried that have not worked over the years, which are all documented in my chart, FYI. However, she won't prescribe Valium, but she says, I can give you Flexeril, which is a muscle relaxer. I can write you a prescription for as many of those as you want. I can refill that prescription for you like every week. Just call me. You don't even have to come in. So that doesn't make sense to me. You can't have a small dose of a medication that we know works and has very few side effects for you. Clearly, I don't have the addictive personality because 30 pills over 2 years, I think, is a safe zone.
It's like, 30 pills over 600, 700 days?
Yeah. But Flexeril here, taken like Tic Tacs. And Flexeril, it does okay, but it knocks me out cold, and I need to be able to function. So
what happens when you take Flexeril for you?
It doesn't do a lot for the pain, but it knocks me out. Yet it's not like a restful sleep. I get like this weird half awake, half asleep thing that I can't function. I can't function on it. So there's no way I could take it during the day.
So you can't work. You can't do stuff at home.
Can't drive. So it's better for me to take that and be incapacitated as opposed to take a half of Valium every week or so.
Yeah, I mean, that would give you 60 weeks. That gives you a little over a year if you're taking a half pill every week.
Yeah. So that was...
And you took the time and explained that to the doctor?
Explained it, and she just would not budge on it. Would not budge. So I said, what's the next step if the Flexeril doesn't work? And she's like, well, we'll have to go through and try other pain meds first. And then this was the part that really kind of set me off. She said, well, I look at you and you look healthy. You don't look sick. Yeah.
It's unbelievable.
Yeah. So apparently if I go to the doctor, I should put dark circles under my eyes and not take a shower for about a week and, make sure that I look sick so that I can get medical care.
So we're prescribing medicine in our healthcare system based on how you look.
Yeah. And not what has worked in the past.
So not objective data,
no.
Not understanding of the disease at hand.
No, no. So
that's just absolutely crazy. That makes me mad.
Yeah.
That makes me really mad.
Oh, I was infuriated.
Jeez. Yeah. So I think this actually is interesting. I mean, that is a very, very different way. We talked about heat and ice earlier today. That is such a different way of practice of medicine and of healthcare than how we practice and how I think a good healthcare practitioner does it. And that's actually reading the person's chart, actually listening to the person. Clearly, there was no listening going on.
No, there was no listening.
I think if we look at dissecting this interaction, I think unfortunately this is probably pretty common for most of the people watching and listening right now. Is you go into the doctor that you got maybe 15 minutes with them if you're lucky.
Her hand was literally on the doorknob for 90% of our conversation.
Right. And clearly she's gotten yelled at by somebody higher up for prescribing Valium because of the whole opioid thing, right?
Right.
Now there's cases where, a pill, for a specific patient is appropriate. There are lots of times where it's not, but I think being able to identify that somebody's had 30 pills over the past 700 plus days is probably not an addict.
Probably not.
And they're like, that just blows my mind. She's just not listening.
No.
At all.
No.
I think that's the number one thing you want to look for when you're looking for a healthcare provider, is somebody who does listen to you, right? I mean, I think of the doctors that you've had and the people that you've respected and that you continue to go to. I think that's the one thing I hear from you, is that they listen to you. They listen to what's going on.
And they don't look at, again, it's like I said before, that protocol of patients are supposed to do A, B, and C. And if you don't fit in A, B, and C, they don't know what to do for you. According to their protocol, Valium is an addictive medication. It's a controlled substance. Therefore, you can't prescribe it unless someone is, I don't know what it takes to get a prescription for Valium anymore.
Maybe you could pay the doctor under the table. I bet they'd give it to you then. But I think that brings up, one of the reasons I left the big hospital system I was at, just all the red tape and the protocols there are, and there's an inability. I think rules are good and protocols are good, but there comes a point where we have to use our education as healthcare professionals to understand when that exception is in front of us,
right? And
actually help the person in front of us instead of making them miserable. I think you said mention something about a handicap sticker?
Oh yeah, that was the second part of the conversation. I was hesitant to bring it up after the whole Valium thing, but I also wanted to discuss the possibility of getting a handicap parking tag to use on rare occasions when I'm having a really bad day and I go someplace where parking is just impossible. And it's come up recently. I've not attended certain functions because parking is an issue. I know that I'm going to have to park, several blocks away, and I'm not going to be able to walk and get to the function. So I just don't go. And it's affecting quality of life. So I brought that up and I made it very clear I'm not looking to use this every time I go to Target. And again, it was well, you don't look sick, you're too young, which, okay, I'll take the young thing once in a while. But
off shoulder there.
Yes, look at me.
You must have looked good at the doctor yesterday.
I must have, but yeah.
Stop dressing to the nines when you go.
It's you're too young to be this sick, and you look too healthy to be this sick. And she says, well, you're still able to work. So is the expectation that I have to be failing at everything in my life before I'm allowed to have accommodations that will allow me to continue with a quality of life? Yeah, I'm still able to come to work, and fortunately I have a very understanding boss who helps me out a lot.
Who has 911 on speed dial.
Yes, we have 911 on speed dial here. But the message I got from her was, until I am bedridden and have given up everything in my life, there's no support for me as a patient. And to me, that's just wrong. Like, we should be helping people to continue to work, to continue to have a life, to keep going, as opposed to waiting until they're, like I said, until they're bedridden before we go, oh, okay, now we'll support you. Now they have so much ground to make up to try to get back to a functioning adult. And I don't know, it's crazy. I don't understand it.
That's just, that makes me mad. That makes me so mad. I mean, there's some days where you come in and I'm like, I go, Teri, you sure you're okay to be here? Like,
yeah.
you literally barely made it to your chair. And from the parking lot to here is maybe 200 yards.
Yeah.
It's not like a mile walk. And I mean, literally you'll come in and it's like, you good?
Yeah.
Or sit next to me. We sit next to each other here. This is basically our little corner.
Yes, we sit in the corner.
But I know I'll look over at you at your desk, and you're grabbing your arm like this. You're like, oh yeah, just kind of that shot of pain that you get. I look at you, and you know what I'm saying, like, go home. And
but I don't.
No, she doesn't. But yeah, I think we need to change how we look at people in medicine, and that we need to change that whole perception of what is sick. Right? Mm-hmm. Sick, I think, historically was, you're bedridden, you're about to die. I think particularly with something like Ehlers-Danlos, where it's a lifelong issue that you've been dealing with for many years. It's going to have a lot of negative effects in terms of cardiac and just general orthopedic stuff. There's just a clear lack of understanding and lack of caring there.
Right.
Or lack of, maybe it's not that she doesn't care about you as a person, but there's a clear lack of willingness to devote the time to look into your condition and actually understand it and have empathy.
Right. And understand that some days are good and some days are not good. My appointment happened to fall in a day that was pretty good. And so maybe I didn't look, maybe next time I go in, I fake it.
Fake it till you make it.
Right.
People say that for a reason. I guess it works.
Right.
But yeah, no, I'm sorry that happened to you. That's absolutely terrible. And unfortunately, I don't think you're alone. So
No, I know I'm not. I belong to a couple of groups, both online and in person, of other people who have Ehlers-Danlos or other chronic conditions. And I've actually fared much better than most. Some of the stories from these people, it's just unbelievable. They go to the doctor, they tell them that they're in pain, that they need some sort of help, and they're told, "Oh, it's all in your head. It's psychiatric. You're overly emotional, overly sensitive. You just need to relax." And they're emotional and overly sensitive because A, they're in pain, and B, they've talked to idiots like that so many times that you get a little
worked up.
You get a little tense. You get a little touchy about it.
I can't even imagine how frustrating that is to go into an office where your hope is that you're going to meet somebody on the other side who's going to be able to help you and hear you, and you walk in and it's just closed-minded.
Yep. Totally shut down.
Totally shut down. They've already made their choice of what they're going to do before you even walked in that door. It's just sad. And I've worked with people like that who in the healthcare industry, I got this patient. Oh, here we go.
Yeah.
In regards to you, when I was working before I was actually working with you, you'd hear other therapists. Oh, here's Stern. She's back again. Now they're complaining about this or that. You just can't make her any better, right? And I think if you can't make somebody better, I think we need to start asking ourselves other questions of why.
Why?
Be motivated enough, be empathetic enough to ask why. Look the extra mile. And I think if you are a doctor or a healthcare provider, therapist, whatever you are, I think we've all had those patients. I can vouch for that. Where I've said in the past, "Oh God, I don't even know what to do with this," whatever. I think that's irresponsible on our part. I think we do need to think about the Terrys in the world who this is how they feel when they leave from that session with us. We need to ask ourselves and force ourselves to go that extra step. Ask ourselves why. Take a little bit of extra time and do the research. With Google these days, there's no reason why you can't find what you need to know.
And people don't want to be in pain. People don't want to go to the doctor. They don't want to go in there and whine. This is not what makes their day. They want to get better. They want to feel better. So they're not doing this for fun.
And I think there certainly are people who are drug seekers, right? That is a problem that we definitely have. But I think it's the professional's responsibility to derive and collect some objective data on somebody to really make an intelligent decision, an informed decision, not to just say, "Oh, Valium's addictive and I can't give it to you," because that's what you're asking for.
Right.
But look at the fact this lady has had 30 of them in 2 years.
Right.
And didn't you said something that she told you, what was it, go see somebody else to get it, or?
Yeah, she suggested that I go back to my orthopedic surgeon. And I was like, why would I take up the time from an orthopedic surgeon when I'm not going to be having surgery?
Just passing the buck.
Right. Just go see somebody else.
Right. Just totally passing the buck. I think this is like the epitome of what is wrong with healthcare. So on that note, that leaves me pretty heated.
Yep.
I think we're probably getting to long enough here today.
Yes, I think so.
So thank you for sharing that story. And anybody else out there who's had that experience, we'd love to hear about it. And sharing your story can only help others. Hopefully, it hits the ears of other healthcare professionals out there and makes us think twice, before we do that.
All right. Make sure you follow us on iTunes, Google Play, Stitcher, SoundCloud.
Yes.
And
right.
And I like thumbs up.
Yeah, thumbs up. No more thumbs down unless you want Teri to be really, really sad. So thanks again for listening. And again, powerforsuccess.com. You can follow us there under the podcast tag. Instagram @powerforsuccess, Facebook @powerforsuccess, pretty much just @powerforsuccess on any platform. And we look forward to seeing you guys next week.
All right. Bye.